Goed. Ik ga de volgende spreker kort inleiden. Dat is mevrouw Serdynska, die een achtergrond heeft in sociaal werk. En die het hoofd is van de Social-Cultural Consultation and Interpretation Services van Children's Hospital in Montreal in Canada. We are very happy to have you here and that you have been willing to travel so far and under such dire circumstances. So the floor is yours.
Thank you. Okay, thank you. I'll speak quite quickly, have a lot of information, so hopefully I will cover it all in time. So I'll speak about advances in equity inclusion in the MUHC, Quebec and beyond. And the objectives are to discuss the reconciliation work of Indigenous acknowledgement and inclusion, efforts to highlight minority language access and interpreter training, and patient partnerships, navigators, and legal services as routes to equitable access. So we're here to look at and improve health inequities. This is the Health Inequalities Data Tool, Social Inequities, and it's looking at children in low-income families according to the market basket measure. So that means families may have the same amount of money to spend on food, but they may end up spending more depending on where they live. If they're in remote areas, food has to be flown in, it's very expensive. If you're a newcomer, you will travel to buy specialty foods so that you can cook the foods from your culture, and you will end up sometimes paying more. So we're looking at two groups that we're going to be discussing today, First Nations and Inuits and Métis identity. So that's in the first chart, and you can see that First Nations are more likely to have children living in poverty compared to Métis, which is a mixed Indigenous group, and the Inuit, compared to the control group, which is less poor. If you look at the immigrant stats, on the other side, you'll see long-term immigrants are doing better than recent immigrants in terms of poverty, living in poverty with children. And the non-immigrant group is less poor again. This is from the Public Health Info Base. It's a very good tool. There's several variables. You can just punch in the information and get the results. In the last year, since the Truth and Reconciliation recommendations came out in 2015, myself and an Indigenous physician began to give workshops on Indigenous history, health and culture. This was in 2015. They went very well. We applied for some funding. We got funding for the first year, and then we were offered funding for another 2 years. So these are just some of the sessions in the last season. We're now on to season 3 and we're finishing up. Culture shock and cultural differences, physicians traveling to the north to remote areas, their experiences and the experiences of the patients flying in from the north for complex care. Cultural safety for Indigenous peoples, end-of-life perspectives for the Cree, and urban Indigenous experiences of healthcare. Interestingly enough, there are more Indigenous persons living in cities than there are in communities or on reserves. The workshops have been highly rated. 74% agree that they strongly agree that they meet the objectives. 21% agree, so it's 95% in total. Here are some images from earlier workshops. This is season 1. The blanket exercise at the top. This is a well-known exercise and it's carried out in different places across Canada. So it's participatory, as many of the workshops are. We all had to stand on different blankets that represented our land, our culture, our values, our families, and slowly those blankets were folded until we were standing on a very small piece. And even some of them then were taken away. It's a very powerful exercise for us to realise what Indigenous people have experienced through the residential school system in Canada. On the right, a similar kind of exercise using a ball of yarn. Each thread represented family, culture, values, and the threads were cut and people were left isolated. They're very moving experiences, again, for us to understand some of the tragedies of the past. At the bottom, we're speaking about Indigenous patients, and this is Evie Mark speaking about Inuit culture and history. So we do have partnerships to work with northern communities. These are partnerships under the RUIS, which is the Réseau Universitaire Intégré de Santé et Services Sociaux. So the partnerships are composed of the MUHC and the Montreal Children's Hospital, because we've had a Northern and Native pediatric team in place for many, many years. The Nunavik Health and Social Services and the Cree, and Ulivik, which Ulivik and Cree Patient Services. Slowly? Oh, okay. Oh, I'll finish late. My apologies, but okay. So Ulivik and Cree Patient Services are the transportation and lodging for patients coming in from the north. So together, through these partnerships, because Indigenous health is federally funded, some extra positions have been created. So we have now 6 physicians, 3 nurses, 2 administrators, and 2 patient navigators who are also interpreters. Here you can see the health regions in Quebec. So Montreal, Region 6, which is down at the bottom. It's the little white patch, you can barely see it, right at the bottom of the map. It's probably one of the smallest areas, is serving Region 17, which is the yellow area. That's Nunavik, that's Inuit territory. And Region 18, which are the small green pockets in the brown area. And these are Cree communities all along the waterways. Closer to home, you have the Kahnawake region, Region 16 to the south of Montreal, and the Kanesatake region, Region 17 to the north of Montreal. These populations also use the hospital, but they have greater flexibility because they're closer to an urban environment and they have more choice in where they go. So we have some policies that meet practices, and one is on the disposal of the placenta. So there are many cultures that revere the placenta. It's considered the lifeline to the fetus. It's accorded special ceremonies, and it is true too for First Nations peoples. So the procedure that we have, first of all, the placenta is considered biological waste. There are guidelines for its disposal. Burial and ingestion is not advised for reasons of contamination and infection, but there is a protocol that's offered to the mother and family who request this, that they understand the risk and they assume the responsibility for the disposal. So there's some education that goes on with the parent before the agreement is made, and then both the physician and the mother or family member signs. Normally, in First Nations cultures, it may be buried under a tree or with special objects to bestow certain qualities in the child's life. So it could be some books or some coins. It's also a popular practice in the Caribbean, in Filipino cultures, and in Indonesia, just to name a few. So this is why we have these protocols. Placentophagy is ingestion of the placenta, which is ground and made into capsules by certain companies that do that. It's thought to have beneficial properties to stave off depression, shrink the uterus, and boost milk supply. There's not enough research currently to say whether this is true or not, but there are lots of people who believe in this. In terms of obstetrics and gynecology, we have now a physician based at the Royal Victoria Hospital. That's part of the McGill University Health Centre. and she travels to the Cree communities in Region 18. She's present there 4 to 5 days at a time, and she's a female physician amongst the history of males. This has made a huge difference. Patients have had negative experiences. Most births have been hospitalized until recently, and now Cree women can give birth in the community. This is less stressful for them, but the complex births have to be flown in to the hospital. And this is always a culture shock. You're told to get on the plane the night before, and you have to leave your family, make arrangements, make sure your bags are packed and come. Obviously, when you arrive, you're not very verbal. You're not very responsive in terms of discussing your medical care or your situation. So time is needed for rapport, to process information. The same question has to be asked several times in different ways to elicit a response. And Cree women in this situation, for example, will say no to everything. No, I don't want that. No, I'm not interested. And so the physician has to really probe and ask why, and do they know really what's involved in the procedure and how it's done, and shows them images from the internet. And then sometimes they've had bad experiences themselves, which is why they don't want to discuss the matter, or they have family and friends who've had negative experiences. So the word goes around the community. So this long discussion is very important. Shopping at the grocery store, attending community events helps build rapport, so they know the physician, they see them around, they know family members, so this really builds trust. Following up when the patient doesn't show up, calling after a couple of hours, asking why they're not there, what happened, I missed you, we really need to see you, please come in, and doing all of that kind of work, which is effective. And then people think, well, this person really cares about us. We have a similar process in place in oncology. There's an infirmière pivot oncologie, and this is a dedicated nurse who follows. I'm not saying it's not just one nurse, but this is the principle of the work. The nurse follows the patient through their care, through their treatment, and works with their family all the way through. So they really develop a bond. This nurse will ask doctors to slow down and informs the interpreters beforehand. If there's critical information to be given, the interpreter is better prepared if she knows ahead of time, or he. The nurse spends time with the patient post-consult. She understands the significance, it's a she in this particular case, but it could be a he, of cancer in the community. So in Inuit and Cree communities, this means the end. If you have cancer, that's it. So she will say, we can cure this, because that's what's the term known in the community. If it's treatable, if you want to say treat, she'll say cure. We can cure this. And if it's terminal, she'll say, we can control this. This is what we're going to do. We can give you some medication to ease the pain. You can come and stay at the hospital, or you can stay at home, and this is how we're going to support you. She knows the community, the culture, and the foods. She takes time to develop trust, and she's aware of the residential school legacy. Does anybody know anything about that here? When countries that have had indigenous cultures, Australia has been through a process, New Zealand somewhat, yes? And so we've treated indigenous cultures very badly, historically. So now we're having to make amends, and we're starting to know the cultures and spend more time in resolving some of the issues. So the nurse can also recommend cultural food. So if someone's having difficulty swallowing, she'll know that from their discussions that porridge and muskrat might be a good combination that they might like. It can be swallowed easily. There's a term that's used for indigenous food, it's country food. And often it's raw, so raw otter or seal. Can be consumed and stored at the hotel. So patients can bring their food with them and they have large freezers and fridges to keep this food. And the nurse will know what foods are suitable and what aren't during certain stages of their illness. And so she may recommend, if hands are dry as a result of chemo, she might recommend softened bear or seal fat, because that's what they use in the community. And then patients feel reassured, oh, she knows our food, she knows our culture. We also are starting to look at the role of the navigator in Canada and in various institutions. So navigator assistance began with Dr. Harold P. Freeman. He was an MD in Harlem. This was in 1979, and he had concerns about patients' oncology care follow-up. And he introduced the navigators, which ultimately improved the outcomes in negotiating hospital care. There are many kinds of navigators. They can be parents, nurses, volunteers. Indigenous interpreters are often navigators, and there are, of course, technological navigating tools. CHIO, which is the Children's Hospital of Eastern Ontario, employs 2 newcomer navigators, and they're in the midst of creating a national navigating network with the Immigration and Refugee Citizenship Canada and St. Paul's University. And their goal is to improve access to care for newcomer families. This has been more, a lot of these new initiatives have been set up after the arrival of the Syrian refugees in 2015-16. The online training will be given to the first 20 candidates free as a test model. There's in terms of technological navigators, there's the Niagara Health Navigator. It's a tool for integrated care, so people can text and make their appointments, make them online, get their test results and so on. And these are just some of them. There's a Travel for Health online tool for minority English speakers in Quebec. So you do have minority English speaking communities in remote areas in Quebec, and they too have to travel for care. So in some respects, they face the same issues that Indigenous people do because of location. And there's a tool that helps them prepare for their trip. At the Montreal Children's Hospital, in the Multicultural Clinic, there's a newcomer navigator in operation, and she's responsible for families who come in with complex illnesses, not easy to diagnose, and also these families need a lot of tests and a lot of vaccinations because it's unclear, they don't have health records, and they often don't come back because they're dealing with other priority issues like housing and getting settled and jobs and so on. So the navigator helps guide the family through the system. She calls them, she follows up, and actually they're quite appreciative. She's also building a repertoire of community services. Sociocultural services, that's the service I work with, has applied for a cultural navigator, and she or he will be responsible for other language speaking families, so those who have neither English or French, and they will, the navigator will work through the interpreters, and she will connect and refer families to exterior services. Because if you call a community group or a local clinic and you're speaking another language, the reception person will not understand you, and they won't necessarily have interpreters sitting by the phone. So these are critical steps. And both navigators will work in partnership. At the Multicultural Clinic, the attendance rate has improved with the use of the navigator. So the blue is the show, meaning they arrive for the appointment, and the red is the no-show. And the no-shows were where an interpreter, an appointment was not confirmed by the navigator. So this is over a 33-week period, so it's definitely having an impact. The number of interpretations that were carried out in the last year are 4,086. Again, Chinese is our largest population. Most of the requests come from Chinese community, Mandarin at 25% and Cantonese at 8%. Arabic has been increasing steadily at 19%, again since the arrival of the Syrian refugees. And Tamil is another significant population, and Vietnamese is growing, as is Punjabi, and you have the others. The healthcare interpreter's role. So this is modified from a Cindy Rote model. I think Hans will recognize that. So this is more of a funnel. The outer rim is the channel for communication. That's the principal role. The secondary role is the clarifier, clarifying key elements of each interpretation, missing information, terms that are not understood. As the dialogue intensifies, you have the role of the cultural mediator. This may be when medication is not working, the treatment plan's not working, maybe it's physiotherapy, maybe it's exercises that have to be done at home, but something's not progressing. What is going on? This is where the interpreter can help navigate the cultural differences. Perhaps mother is cooking traditional foods, perhaps there are a lot of other children, father works late, comes home late, and there isn't time to properly administer the medication. Perhaps the exercises are not culturally appropriate, and mother doesn't feel comfortable doing them, because it's often the mother in these cases. Sometimes the father is working out of the country, and so mother is managing alone. There is interpreter training at Dawson College. It's an attestation d'études collégiales, and it's in language and cultural interpretation in health and social services. So that was a partnership between Dawson College, Montreal Children's Hospital, and various other school boards in order to set this up. And there are 9 or 10 courses, depending which population you're coming from. So it's also for Indigenous interpreters. So Indigenous interpreters will learn more about the history of their culture and background, and the immigrants, the international interpreters will learn more about the immigration and refugee experience, reflecting their populations they'll be working with. And there's also a section there on self-care skills. So the 10 Indigenous interpreter navigators will graduate this year. There had to be some amendments made to the criteria, because this is all very formal language. It has to be passed by boards, educational boards. It has to be passed by the Ministry of Education. So there were some pieces that didn't fit, and they had to be amended. And so it's taken a bit of time. The next group that the focus will be on the international interpreters. And there are some discussion at the ministerial level, orientation ministérielle concernant la pratique d'interprétariat. So in the more recent document, they distinguish between formal and informal interpreters. Informal interpreters being employees, volunteers, family, friends. Formal interpreters coming from a designated bank of interpreters. There's a growing need for interpreters in outlying regions of Quebec, because a lot of immigrants and refugees are being directed there, but they don't necessarily have the services. So that's the problem. So we need more interpreters outside of Montreal, for example, in Quebec City. There is a diversity of training and experience of interpreters that's been acknowledged. Some of them have a background in translation, in education, teaching, health. So that has to be accounted for in the building of standardization. There are communities facing linguistic barriers. So as I mentioned, Anglophone or minority English-speaking communities in outlying area, ethno-cultural groups, and First Nations. So We know more about the Inuit and the Cree interpretation needs, and there are designated services, but some First Nations groups are speaking their language, but we don't know to what extent the need is yet for interpreters, because many of First Nations groups also speak English. So that has to be identified. And there's a call for policies, there's a call for the need for policies to outline the linguistic barriers facing communities and taking steps to remove them with trained interpreters. And this is for quality reasons. The Banque Interrégionale d'Interprètes in Quebec City are to liaise in building satellite offices using technology. There's a booking system called Jérôme Plus that they use, online booking system. So they want to incorporate that across the province to facilitate the reservation of interpreters. First of all, they have to recruit more and standardise training. So at the Children's Hospital, we did update our interpreter policy and procedure in 2018. There was an original one, but it really was just a paragraph. It really did not go into any depth, and this one does. And the summary is here. Under the umbrella of equity, cultural inclusion, patient safety, and informed consent, this policy recognizes the need for designated paid interpreters to be assigned to patients' families with limited English or French proficiency for interactions with healthcare professionals. And the references include the Migration, Equity and Diversity Task Force, among others. The policy covers the need for translations of medical documents and educational materials, and calls for, encourages participation in research of other language speakers. The procedures outline how to access the different kinds of interpreters, and the international, the indigenous, ASL and LSQ, which is sign language for the deaf in English and French. And it also advises building interpreters into budgets for research. There's quite a bit of interpreter development in Canada, but it's diverse. So there's the Interpreters Lab in BC, and they offer online interpreter training. The Ontario Council for Community Interpreting, which is an umbrella group, an overseeing group that looks more at accreditation and standards. ALIA, the language industry, they have links to community interpreter training courses, and there are quite a few of those. And in Quebec, it's OTIAC, and that's for terminologists, interpreters, and translators. And they, again, look at standards, ethics, etc., and certification. Dawson College, I mentioned already, and Nova Scotia Interpreting Service asks that their interpreters be ILSAT trained. And ILSAT is a standard that's used in Ontario and different other parts of the country, but not in Quebec. So there's a difference there. We have several patient partnerships at the McGill University Health Centre. Over the last time I discussed this, there were over 70, so probably there are more now. And the partnerships take place at every level in the organisation. And what we're going to be doing when I get back is to start looking at incorporating equity into the standards of, the equity standards into the framework of the partnership, promote diversity in patient partners and communities. So that could be, for example, having another language speaker present at meetings with the help of an interpreter. So it's taking the extra steps. It could be having someone who's undergoing housing transition, living in a shelter, or sharing accommodation with other family members. but wanting to have their own home. This obviously all of this impacts on health, and that person could be present, and we have to make sure that we facilitate the core values of equity in that. So we have to make sure that we pay for childcare and that we pay someone's bus tickets or provide lunch when they come, so that we can make sure that people are present at the meetings. And we have to make sure that all populations are heard and represented in surveys. So right now, the surveys are sent out randomly in English and French. So obviously, if you speak another language and you're not proficient, you're not going to fill out the form. So we're looking at making the forms available in at least the most spoken other languages, which might be Chinese, Tamil, and Arabic. Currently, that's where we are. So this is the next step here. In terms of the MUHC Reproductive Centre, they have many partnerships, but they have a partnership with the LGBT Family Alliance, and they've had an open house. They've carried out education with staff and the public on same-sex parenting and surrogacy, and this has been very helpful to the community and to the staff on being culturally appropriate in terms of their interactions with patients. On average, there are 38 female couples a year who undergo fertility counselling and or treatment, who use the services. There's an increase now in the number of male couples. Last year there were 15, and this year there are already 14, and the year is not complete. There is good legal information available from Educalois. They provide information in English and French on reproduction, same-sex parenting, adoption. It's user-friendly, and it covers many aspects of family law. We have also medical legal partnerships, MLPs they're called, with Justice Pro Bono. 60% of a person's health is determined by social factors. That's been mentioned earlier today. The MLPs were initiated by Dr. Zuckerman in the US in the 90s. There are over 300 there. There are others in Canada, quite a few less. But the first one was at Sick Kids in Toronto. The MCH partnership with Pro Bono was the first in Quebec. It's still relatively new, as of February 2017. And since then, there have been 176 cases. The legal advisor also provides training for staff on recognizing some of these concerns amongst patients and families, and they provide some advocacy for laws that are discriminatory in accepting people who don't fall into the usual categories. For example, we had a mother from Chile. She was pregnant when she arrived. She was working here short-term on a contract. She had a complicated birth and pregnancy. She could not go home. It was advised that she stay and have her baby in Montreal. She did. The baby had a complex illness. She couldn't go home because the treatment wasn't available back home, but she was caught in limbo without proper medical care, with medical coverage. So some challenges were made to the law on this point, and I think she now has coverage. By far the largest area of concern is immigration in terms of legal issues. We work also with IWK, that's a Women and Children's Hospital in Halifax. They also participate in assessing themselves against the equity standards. They have a lens tool which has to be used. I don't know if you can see that very clearly. They have a lens tool that has to be used in all new initiatives at all levels. So they have to look at how gender is represented, how sexual orientation is represented, culture, religion, literacy levels, etc., immigration and so on, so that each project has to make sure that they've looked at these components. And to finish, there are proposed guidelines for Indigenous inclusion, both at the IWK and both at Montreal Children's Hospital. So, for example, in Halifax, IWK is located on the Mi'kmaq territory, and they are proposing a land acknowledgement. Land acknowledgements are happening at public meetings across Canada. So if you have an award ceremony, someone will say, first of all, I'd like to acknowledge that we are on unceded lands of a particular Indigenous population. At the Montreal Children's Hospital, we would say, for example, the MUHC acknowledges the Ganagahaga Mohawk Nation as the original inhabitants and gatekeepers of the land on which we are located. So I say that every meeting. Other people do. We've had grand rounds. I've encouraged the physician introducing grand rounds to make these statements. People look it up. They say, yes, this is appropriate. We'd like to do this. So we're waiting for acknowledgement from our administration. And I was informally told on Friday that it was going to go through the process. It has to go to the board. We're also looking at, and this is just part of the statement, the statement is quite a bit longer. It's obviously in partial implementation due to the work we're doing, so it really is just now to be formalized. We're constructing a Wachia room for families. That's a welcoming room for patients traveling from the north so they can rest when they arrive or after their appointments. And the Indigenous inclusion statement must come with a health equity statement. So we have prepared also a health equity statement. So the two would come together and the approval should come together. One complements the other. In terms of acknowledging our Indigenous culture, we commissioned a piece of art. This is Natalie Coutu. She's sending regular updates of the work in progress, and we hope to see the finished version very soon. Merci, dankia, thank you, and thank you to all of our contributors, because obviously this came from many places.
Thank you very much, Marie, for this overview of what is being done in Canada.